All right. Today we're just going to talk about how I've incorporated MicroPulse into my practice. I'm a comprehensive ophthalmologist that is also involved with residency education. I've been using the MicroPulse now for about 3 years, and hopefully I can show you a few slides today that will kind of help solidify a little bit about what MicroPulse is and how you can use it in your practice too. So some of the goals of the lecture, what we're going to talk about today is how I've incorporated the MicroPulse into my comprehensive practice and what MicroPulse technology is, along with how we use it for the anterior segment as well as the posterior segment, and being able to use it for various treatment techniques. First and foremost, when we talk about any procedure or anything you're going to do in regards to patients, the first and foremost thing that you always want to concern yourself with is really patient safety. And safety becomes a big issue because we don't want to create any harm. The first thing we learn in medical school is to do no harm. And really the safety profile of the MicroPulse laser is wonderful because it's foveal friendly, it causes no tissue or thermal damage to the tissue, and it is repeatable. So from a safety standpoint, it fits those criteria. Its efficacy is there. I'll show you some of my case studies and how I've incorporated and the effects that I've gotten with the laser, and also some studies that will show how the laser works and how it's efficacious. And the efficiency of the laser with the tech cell, I'm able to treat areas of the retina very quickly, very efficiently, and that's good for not only me as a physician who's doing the treatment, but as your patient, you don't want to have someone aiming a laser at you for a long period of time. So as a patient, it's nice to have something that can be done very quickly and very efficiently. And from an economic standpoint, one is it'll help reduce the cost to the patient over time, because if we can use a technology like MicroPulse to at least decrease or diminish the amount of times the patient ends up having to come to your office, they'll ultimately reduce the cost to the patient and also to the healthcare system. For the practice, having one laser that can do multiple things also reduces the cost. So if I can have a solid-state laser that can do glaucoma, that can do retina, that I can treat PRPs, I can do focals, I can do laser sutural lysis. I can do many things with this laser, and it's only one laser. I can reduce the expense to the practice and also the amount of space I need within my practice for that laser. The other thing, too, is ultimately if these patients are happy in your practice, they'll tell their friends and everyone else will start to come to you, too, and ultimately that does lead to an increase in your practice revenue. So let's talk a little bit about what MicroPulse technology is. If you think of a continuous wave laser, as the laser energy is applied to the tissue, heat is generated, and the longer the duration of time or the higher the milliwatts that we use, the greater heat is going to be generated and ultimately create a thermal burn. So now if we can take that laser energy and actually section it up, and by sectioning it up, what we're doing is cutting into multiple trains of energy, and you can set those trains wherever you want. If you want to do a 15% duty cycle, a 10% duty cycle, or a 5% duty cycle, the less the duty cycle is, the less energy that's going to be delivered over that period of time, and therefore your thermal effects will also be diminished too. So the idea behind it is what we're trying to do is to actually use the laser to create the biological effect without causing the tissue damage that we would have traditionally with a continuous wave laser. So how does it work? Well, what happens is when the laser energy is applied, we know that heat is generated within the tissue, which will then release the biomediators that we need to get the effect that we're looking for. With a conventional laser, which is the picture over to the far left, we actually create a thermal burn. So the thermal burn is created. The problem is that's not good for the tissue, but it's the area around the burn is what's releasing the biomediators. So if we think about it for a moment, if we can get the same effect without causing the tissue destruction, wouldn't that be better? And the answer is yes, and that's where MicroPulse comes into play. So if we can use the MicroPulse technology, not create the thermal burn, but get the mediators to be released and get the biological effect that we're looking for, all the better we are. So currently right now I use the IQ532 with the tech cell, and we'll talk a little bit about the tech cell, but what it allows me to do is to be able to put a very confluent pattern grid over the area of the lesion or the area of the retina that I need to treat. It gives me really a predictable, consistent laser delivery. When I was using the original IQ532 laser without the tech cell, I was getting very nice effects and very nice results too with it. But you'd have to do more of like a paintbrush technique where you kind of hit the laser and you move from spot to spot. And you eventually get pretty good at that, going back and forth and up and down. But as you'll see in a video coming up, the tech cell will give you a more consistent area of where you're applying that laser. And I think ultimately you get a better effect, and also it makes the efficiency of the laser that much better. So how have I used it in my practice? Well, I'll use it as a first-line treatment. I know a lot of people are saying, well, is laser really ideally being the first-line treatment when you're dealing with patients and their disease process? Well, if we look at glaucoma, in the past, medications were kind of the gold standard for the glaucoma therapy. And today, still, medications are very valid and very useful. But now we can switch, and there's been a lot of switch to going towards using ALT or SLT and now MLT for the treatment of glaucoma. And we'll offer that to the patient as a first-line therapy. When we're talking about diabetes, you'll also see in some case studies that will show how diabetics can be treated as a first-line therapy versus just anti-VEGFs alone. And also I'll use it in combination with pharmacotherapy. If we're not getting enough effect, we can still add medications afterwards and they'll still work. And for retinal applications, we can use it for a variety of things. I just mentioned a few, such as diabetic macular edema or branch vein occlusions, MACTEL, and radiation retinopathy. So at first now, we're going to kind of switch gears and go right into glaucoma, and I'll talk to you a little bit about what I call MLT or MicroPulse laser trabeculoplasty. So when we look at traditional ALT and SLT, what we're seeing is that the laser energy that's applied in ALT is being applied in a very small spot size, targeted at the area of the border of kind of the trabecular meshwork of the pigmented and non-pigmented. And what we used to think it did is it kind of shrinked up the tissues so that you would cause contraction in one area and actual expansion in other areas to open up that trabecular meshwork. Well, we really know that that's not true anymore. It's more due to the upregulation of these mediators and macrophages and everything else that take place. The problem is, though, with traditional ALT treatment is you're creating a thermal burn. That thermal burn that you're creating within the trabecular meshwork is there, and it's always going to be there. So you're limited in the sense of how many times you can apply the treatment. Typically once. Sometimes you may try a second treatment, but then you do run into the process of creating peripheral anterior synechiae and more thermal damage to the trabecular meshwork, which can actually cause a problem with the pressure going up instead of down. We then now start looking at SLT, and SLT, we know that that targets intracellular melanin and the macrophages, cause the upregulation within the trabecular meshwork to help facilitate the outflow through that. We know SLT doesn't really cause any thermal damage. However, sometimes you can see a little pressure spike with SLT. You can see the pigment dusting that can take place with SLT. SLT, though, does have the ability to be repeated, uses a large spot size of 400 microns, but it does have somewhat limited use in the sense that the laser is designed just for SLT. Unless you get a combo laser, which is SLT YAG, but still very limited in the sense of what you can do with it. When we look at MLT, it's very similar to SLT in the wavelength. So using a 532, you can use the 577 for MLTs also. It causes minimal to no damage to the tissue. It targets that intracellular melanin and activates those macrophages to allow the facilitation of outflow through the trabecular meshwork. It uses slightly a smaller spot size. We use a 300 micron spot size, so if you have a little bit narrow of an angle, you can probably squeeze it in a little bit easier than the 400 micron spot size. We really don't see any post-op inflammation. I wrote minimal. I really don't see any post-op inflammation, so we don't use any pre-op or post-operative medications in these patients afterwards. The laser is repeatable, and also, once again, we have multiple uses of this laser. So this is a nice slide. I always like to show this slide because this is kind of showing you what's going on in the trabecular meshwork. So with a 50 micron spot size, 100 millisecond duration, and 1,000 milliwatts of power, you can actually see on this E&M slide, the trabecular meshwork, the actual burn that takes place from a traditional ALT procedure. If you look at the MicroPulse treated eye, you don't see any changes within the trabecular meshwork, and that's using a 300 micron spot size, 300 millisecond, and 1,000 milliwatts of power with a 15% duty cycle. So you compare that MLT eye to that of the control eye, really no difference at all. So that shows you that we can still get the effect without causing the tissue damage, which then allows us to make this procedure repeatable in the future if needed. This is courtesy of Ike Ahmed. This is just showing you what it would look like as a treating physician. What you're basically doing is taking a 300 micron spot size and laying those 300 micron spots right next to each other across 360 degrees of the trabecular meshwork. With the laser itself, you probably will be putting in somewhere between 95 to 120 spots, basically about 10 spots per clock hour. The nice thing is Iridex actually has worked on making a lens that has a little clicking device on it, which actually rotates each clock hour. So you can say, okay, I need to put 10 spots here, click, need to put 10 spots here, click, 10 spots here. And so by the time you go around 360 degrees, you've made your treatment and you've known how many spots to put in. So what I wanted to do is just show some of the data from my earlier work. I started off first using 300 milliwatts, and the question was why? No one knew what power settings to use. So we were kind of being the principal investigators in this, and so at first I started off with 300 milliwatts of power, and basically I looked at patients at a 4-month period, and at that time we saw about an 18% reduction in power, not in power, in pressure. We then said, well, that's pretty good, let's move up the power setting a little bit, let's go up to 700 milliwatts. And then we looked at them at 1 month and 4 months, and what we saw is that at 1 month is about equal to that at 4 months at 300 milliwatts. But by 4 months, the pressure went down a little bit further, down to about 22% reduction in pressure. We then decided to move up to 1,000 milliwatts. And why did I kind of choose 1,000 milliwatts? Well, if you go back to that histopathological slide earlier with that E&M scope, we know that 1,000 milliwatts is not going to cause any destruction to the tissue. So I felt very comfortable at that point using 1,000 milliwatts. And what we see is that nice dose response curve in that at 1 month we saw about a 22% reduction. By 4 months, a really nice reduction, about 30%. And then by 12 months, a little fall off or a 26% reduction in IOP. This is now my 2-year data that I'm presenting today. And if we look at it, we do see a little bit drop off further down to a 24% reduction, but still a nice effect by 2 years out with the MLT procedure. There was 2 eyes that had no effect at all, and if we were to take those patients out of the study, we'd have about a 28% reduction at 2 years. So for those that did respond, we saw an average of 28% reduction. For all comers, we only saw about a 24% reduction, but still a nice effect from treatment. When you looked at a multi-center study, this is a collaboration with Ike Ahmed, myself, Nate Radcliffe out of Cornell, and Steve Old from Bold Vision. What we did is we took all our data together, and this was some earlier data. We're going to actually try to put more data together again and update these slides, but at 1 year we were seeing about a 25% reduction in pressure, about 6 millimeters of mercury after treatment. And more importantly, these patients were already on medications. The average medication was 3 medications before they even had treatment, and we were able to actually reduce some of the people on some of those medications down to 2.8, but a nice dose response curve over time. And here we are with patients that had a pre-op pressure a little bit less to begin with, basically patients who had a pressure of 18 and a little bit higher, and we saw about a 4.5 millimeter drop or about a 20% reduction in IOP. But more importantly, again, we were able to reduce those medications down from 2.9 to 2.3. So what are the treatment pearls with doing MLT? What I like to do is to use that 1,000 milliwatts of power, 300 micron spot size, 300 millisecond duration, and a 15% duty cycle. I treat the entire 360 degrees. I know with the traditional ALT you may do 180, and with SLT you weren't sure, you did maybe 180 or 360, but I think 360 works best if you want to get a good effect. We don't use any pre or post-op medications, and I typically will follow these patients up at 1 month to see how they're doing, seeing how the effect's coming. If they get an effect at 1 month, we don't do anything because we know by 3 months or 4 months out, it's going to be a little bit better effect, and even a year out, it's still going to maintain. So we don't do anything differently unless obviously their pressure was high, so high that you felt that the nerve was going to be compromised, and then obviously you may do something in addition to just the laser alone. So the role of MLT, I think in my hands, is really, it's great for those people who have lost effect from medications or previous laser in the past. You know, tachyphylaxis is real common with medications over time. Eventually they work, but eventually their effect goes down. So I think it's a nice adjunct to that. People who have had inadequate response to laser before, if they've had a previous ALT and failed, you can do this laser. If they've had a previous SLT and failed, you can do this laser. So it's an option for you. It gives you another device that you can offer these patients to help with their disease process. And from my standpoint, it really benefits the patient and the doctor because one is if we can reduce the amount of medications on board, that makes it a lot easier for compliance. A lot of these patients are a little bit elderly. They have a hard time, one, putting the drops in their eye, and if they're on more than one medication, then they usually have a tendency also to get keratitis and dry eye and other issues that comes along with the medications itself. So if we can improve their quality of life, that's even better if they're not having to be always regulated by where are my drops, I got to find my drops. And once again, this laser has great applications for both the anterior as well as the posterior segment, which is what I'm going to talk about now. And so we're going to switch gears to doing basically MicroPulse for various etiologies within the retina. So when we look at the TechCell for the retina, what the TechCell allows us to do is to basically give us a pattern of laser treatment. So when you look at continuous wave laser, like we discussed before, we're going to create a thermal burn, and it's the halo effect or the ring effect around that burn is what's going to release the biomediators you need to improve the retinal edema. So once again, if we can cut out that thermal destruction and just get the release of those biomediators from tickling the RPE with the laser and not causing that thermal destruction, then we're going to be much better off. The big thing with MicroPulse, and what I would stress to you, is that when you're dealing with retina, you don't want to use anything higher than a 5% duty cycle. You want to make sure you keep it at a 5% duty cycle, or else you could potentially run into a thermal burn. And the other thing is the high density protocol, meaning that you want to put a large area of high density treatment in that area of edema. The high density is done easily with the TechCell because it lays the laser right next to each other, and you can apply a great pattern in that area. And I'll show you a little video about that. So this is showing what the TechCell looks like. When the TechCell goes on, you'll see where that laser is going to be delivered, and then you'll see it going across side by side, back and forth. And this is using a 7x7 confluent grid, so there's zero spacing. You can adjust the spacings depending on how you want to do it. Power-wise, this was using a 200 micron spot size, 200 millisecond duration, and you can use anywhere between, say, 300 to 400 milliwatts of power. I usually like to start off with a little bit less power. Now that I'm using the TechCell, I have seen a little bit of areas of reactive edema in areas of non-edematous retina to begin with. So what I found is that actually backing off on the power has actually been beneficial. So what I've found is that backing off to, if you're using a 200 micron spot size, I think 300 micron or milliwatts is a nice starting point. If you don't see any biological effect, you can then bump that up. Or if you want, you can also do the titration method of being able to titrate the power setting, and we can discuss that a little later. The other thing too is we've got to remember that this laser is also a continuous wave laser, so it's great for doing PRPs. You can set up a grid. I like the 3x3. It's better in my hands for when I'm doing a PRP because a 7x7 gets a little bit too large because you're using a much larger spot size and you're covering a much larger area of retina, and you'll see my PRP kind of drift off to the sides, and it just doesn't look pretty. But when you put this in, it's great. You just, boom, you hit the foot pedal, you get your 9 shots, 9 shots, 9 shots. And the nice thing for the patient, it's very comfortable, especially the 577 laser. You can basically do a PRP with almost no pain. I mean, absolutely zero pain. So here's some cases I'll talk about. I'll give you about 10 cases of some retinal diseases that we've treated. This was a patient who had diabetic macular edema. They've had avastin a year prior, but then had a stroke. And so we talked about that risk factor. And he said, you know, I don't want any more injections. I don't want to have another stroke. This one I got through, I was fine, but I really don't want to have that risk factor again. So we went ahead and treated them, and this is 4 months post-treatment. Visual acuity improved from 20/50 to 20/30. We see some nice resolution centrally of their macular edema. So in this case, this was worked out very well for them in the sense of that we can reduce their edema, improve their vision without increasing their risk for stroke. Here's another patient who had chronic macular edema. They had multiple continuous wave laser grids in the past. This is like one of my first cases. This is back in December of 2011. So at first, you know, you're a little bit concerned about treating over that area, which is the fovea. And so, you know, you have to have blind faith and you go forward with it and you treat it. And so in this case, this is 3 months post-treatment. Visual acuity improved from 20/50 to 20/30 with nice resolution of the edema. This is another case of chronic DME. So here's these cases where you come in and you inject them, next month come in, inject, next month come in, inject. And this person was injected 5 times and really no resolution of their edema fully. So we decided to do a MicroPulse in December of 2011. And this is 13 months post 1 treatment with no additional anti-VEGFs. So we can see a nice improvement from 2200 to 2050 with resolution of the edema with no more adjunctive therapy, no more need for a second MicroPulse at this point. So this person did very well with treatment. Here's another case of chronic macular edema due to vein occlusions. For some reason, and I'd like to probably get all my vein occlusions together and write a paper about, because vein occlusions love MicroPulse. I don't know why, they just do. It seems like they respond the best to MicroPulse. And so this person had multiple continuous wave grid treatments in the past, multiple steroid injections, really didn't respond too well. Visual acuity of 20/60. They ended up with MicroPulse, and 11 months post 1 treatment, visual acuity improved from 20/60 to 20/25. No more adjunctive therapy, no additional laser, no additional anti-VEGFs or steroids, and this person did very well with just 1 treatment. This was my wow case, and as soon as I had this wow case, of course, I sent it to Joan to show her, but this is a patient who came into the office with no prior treatment, had a vein occlusion, said it's been there for probably 2 or 3 months. We talked about and discussed treatment options for her. She elected to have the laser done. Visual acuity was 20/50. And here we are 7 days post 1 MicroPulse treatment. Now, typically we don't see effects like this at 7 days. For some reason, she responded very well. And I never see patients back in a week after treatment either, but this patient actually came to the front desk for another reason and said how wonderful her vision was doing. And I'm thinking, well, she had laser done. She's probably just thinking it was the laser. I had LASIK. I had, you know, of course my vision's gonna be better, you know. She's thinking everyone has better vision after laser. And so I said, well, why don't you come on back? And we put her on the OCT, and this is what we saw. And I was pretty impressed at that point, you know, just seeing how well these vein occlusions respond to MicroPulse. This is another vein occlusion. This is a patient who had avastin and MicroPulse as a combination therapy. So in this patient, their count fingers at 6 feet. They had their 1 avastin injection. We see some nice resolution of the edema. Visual acuity improved to about 2300, but still a very thickened retina. Here we are after 1 MicroPulse treatment. So this is looking at the patient after they've had their 1 avastin injection, and then now after a MicroPulse treatment. And we see the visual acuity being about the same, about 2300. We actually may see even a little bit of an area of what we call reactive edema by treating a little bit outside of that area of edema. Sometimes you can see that little bit of reactive edema. But overall, vision stayed about the same, but definitely a lot less edema noted within the retina. So at this point, this was further along the way. This is in August. We still saw that 1 section of edema that just didn't really resolve fully. So at that point, we opted for a second MicroPulse treatment, and the visual acuity improved even further from 2300 to 2100 with more resolution of the edema. So if we go back to those pictures, this was pre and post combination therapy of just 1 avastin injection and 2 MicroPulse treatments with a nice resolution from count fingers at 6 feet to 2100 vision. And this is the next case of radiation retinopathy. Now this is a patient who has chronic macular edema. They had radiation retinopathy for ocular lymphoma. It happens to be my golf partner. And he came in complaining of some new metamorphopsia. When he was trying to line up his putts, he was kind of noticing it, and I said, well, let's see what's going on. So we looked at him, we discussed possibilities of, maybe Avastin, MicroPulse. And so in his case, what we did is we went ahead and treated him. And at 17 months, just after one MicroPulse treatment, his vision improved from 2100 to 2080 with resolution of the edema, and that's all he's had was just one treatment, and he was done. Now his visual acuity remains at 2080, and that's mostly due to foveal ischemia. If you look at his fluorescein angiogram, his FAZ is much larger due to the previous radiation, and so visual acuity is going to stay about 2080, but he was very, very happy the fact that it got rid of his metamorphopsia that he was having. Another case is that of MacTel. MacTel is very difficult to treat, especially even with anti-VEGFs. It doesn't seem to respond super well. And it's also very difficult to treat with continuous wave laser because you really don't want to be treating right next to that fovea or in the foveal vascular zone with the continuous wave laser. You're going to create more problem, more harm. So this is a great one for MicroPulse. This patient had 20/40 vision prior to treatment, and here we are after treatment. We got rid of that little area, the metamorphopsia went away, visual acuity improved from 20/40 to 20/25 after treatment, and this is 13 months later with just one treatment again. Here's another case of diabetic macular edema. This patient had a history of proliferative diabetic retinopathy, had PRPs in the past, multiple continuous wave laser treatment, had multiple focal treatments with that. They had no adjunctive therapy and no prior MicroPulse treatment. We see a large patch of edema, visual acuity of about 2400. And here we are about 2 months after. This is just kind of showing a Texel treated eye. 2 months post-treatment, visual acuity still remaining about 2400, even though we were able to reduce and remove that area of edema. So when we look at it, if we were to look at their ganglion cell layer, we can see that their ganglion cell layer is shot. I mean, if we can remove the edema all we want, and still probably not going to do a whole heck of a lot for this patient. But for those patients, you can still attempt or still try and see if you can get rid of some of the metamorphopsia that they may have. So it was a good result, but a kind of a so-so outcome, It happens. And this is another case of a patient with diabetic macular edema and also a vein occlusion, kind of two in combination. Visual acuity of 20/40, no prior treatment. This patient had a Texel laser done also. 6 months post, one treatment, visual acuity improving from 20/40 to 20/25 with nice resolution of the edema. So like I said, branch vein occlusions really love MicroPulse. It seems like they do real well with the treatment. So some of the treatment pearls I have to say with MicroPulse for retina treatment, we want to use adjunctive therapy still. We don't want to stop using anti-VEGF therapy. We want to decrease the retinal edema as much as possible, and that helps with the laser. But if those patients who can't tolerate anti-VEGF therapy or are afraid of having a shot in their eye, this is an option for you to be able to do this as a first-line therapy for treatment to see if we can get the effect that we're looking for. Also, the thing we know about diabetes is that early treatment of mild edema, one, will respond better, but two, it'll help preserve vision longer and better for these people. So even with a little bit of edema, we can go ahead and start thinking about treating earlier and using the MicroPulse to better the patient's outcomes. And remember, when you are using MicroPulse in the area of the retina, you want to maintain that 5% duty cycle. You don't want to increase that at all because we know at 5% we're safe, but anything higher than that, you do run the risk of creating a thermal burn and destruction of the retina. And sometimes with post-MicroPulse treatment is that watchful waiting. Sometimes you'll treat these patients, and as long as you still see a decrease on their OCT of their central macular thickness, or an improvement in vision, you don't necessarily have to jump in and retreat right away. You can see as over time these people continue to improve. Now it's not as, if you want to use the word sexy, as anti-VEGF therapy. You don't get that wow effect right away, but it does work and it does save that person the risk of having an anti-VEGF therapy being performed on them. So what I'd like to do now is just talk a little bit about some of the studies that supported MicroPulse treatment. A lot of these slides came from Elias Rochelle's talk over at American Society of Cataract and Refractive Surgery. So when we talk about using threshold versus MicroPulse, you can see how with continuous wave laser you create a thermal damage or a thermal burn within the retina. While in the MicroPulse treated eye on the right side, you can see where the effects of the MicroPulse was created, but we saw no thermal damage to the RP layer. The other thing too is that when we look at MicroPulse and the clinical efficacy, when you compare continuous wave laser to that of MicroPulse, they both work. I mean, continuous wave lasers worked for years. It was the gold standard a lot for people with diabetic macular edema or clinically significant macular edema. And so you go ahead and use the continuous wave laser and treat them. And with the modified ETDRS, we're using a little bit lesser thermal damage because we're backing off on the power settings. We still get a nice effect, but if you look at the eye itself, you're still going to see thermal damage within the retina, and you can see that on the fluorescence exam over there. But when you compare that to MicroPulse, we don't see that. We don't see the thermal effects in the retina, so we're safe there. The other thing too is the microperimetry that is performed on these patients afterwards actually improved, meaning that the retinal sensitivity got better after MicroPulse compared to that of traditional continuous wave lasers. So that was another added benefit of MicroPulse treatment. This study was looking at three different people, kind of looked at using 810 diode laser. So there is the three parameters. We have the 810, the 532, and the 577. And so what they're doing is looking at using high density, low intensity MicroPulse over the area of the retina. And basically what it showed was that in one study it showed that the modified ETDRS was very good at stabilizing vision and the macular edema, but also the MicroPulse was as effective as doing that. And in Levinsky's study, basically he looked at what's the central macular thickness and which one did better. Was it the modified ETDRS or that of the MicroPulse? And actually the MicroPulse did a little bit better in his study compared to that of the modified ETDRS. And the other one was from Luttrell. And Luttrell's study is very important because what that did is it showed that for a 10-year period, these patients who were treated did not have any thermal damage to the retina over a 10-year period. So people say, well, you know, you treat them and then what happens long term? You know, we know the effects of like PDT, sometimes you get this other process and subretinal fibrosis. What about MicroPulse? Is that going to create the same effect and same problems down the road? Well, at least in his study, you know up to 10 years that you're safe with use of MicroPulse. This study then kind of showed taking 810 and comparing it to the 577, and what they showed is that really it didn't matter too much on the wavelength. You do have to adjust the powers and make those differently between the 810 and the 577, but really there is no difference between the 810 or the 577 in their treatment effects on these patients, and that they both worked well. So when you looked at the baseline central macular thickness, and you compare that to the post-op eyes, whether you're using the 810 or the 577, they both had a decrease in that central macular thickness, and they both did well. So from that standpoint, that verifies that whether you're using the 810 or the 577 is fine. The 532 probably would fall along with the same guidelines as the 577. And then once again with Luttrell's study, which was extremely important, was that the 5% duty cycle on these treated eyes cause no retinal damage, and you can see that, you know, by looking at fluorescein autofluorescence, whether you're doing an ICG, fluorescein, or OCT, you're not going to see any thermal effects or thermal damage. And these patients were followed up, like I said, up to 10 years out. The other thing too is that Levinsky looked at what is the best way of treating these patients. Was it using a high density or a low density treatment, or was it the modified ETDRS protocol? And really what we found is that high density, low intensity treatment by far is still the best way of treating these patients. And lastly, the slide is the DCR net width, which is protocol 1. And when you look at that, what group really did the best? It was those patients who were treated actually with anti-VEGFs first and delayed laser. So laser still has an absolute role in the treatment of diabetic retinopathy. In fact, actually the purple line on the bottom is just laser alone. That's sham plus laser. So we know laser works. Now can we use it in adjunct to the anti-VEGF therapy and get a better effect? And the answer is yes. Now this was done with continuous wave laser. The thing about continuous wave laser, we know it works, but you're also creating thermal damage. And we know that when you look at the earlier studies, that MicroPulse actually did better compared to the modified ETRS with thermal laser. So the question is, can we push the threshold earlier? Meaning that can we do MicroPulse a little earlier than waiting 6 months for deferred laser? And I think the answer to that's yes. I mean, we've shown it in some of my case studies on how just MicroPulse alone can treat retinal edema, or how MicroPulse with the use of anti-VEGFs can be beneficial, especially in those patients who have a really thick retina that you're trying to bring down and allow that MicroPulse to work a little bit better. So in conclusion, MicroPulse is very good. It's an excellent laser treatment choice. It causes less tissue destruction and no really tissue destruction seen that we can visibly see. Some of the case studies I showed the preservation of vision and function, and that anti-VEGFs still have a role and they work, and they're still needed to be used. We don't want to forget about them. And that we also know that anti-VEGFs along with laser was probably the best choice according to the DCR Net Protocol 1. And that MicroPulse is really a safe technique and a safe process to use. And for those who are Michigan State fans, go State, take on Indiana today, and hopefully we'll win. So at this point, I'll entertain any questions. I'll put my ears on so I can hear your questions and go from there.
Thank you very much, Dr. Gossage. Appreciate it. Good talk. And we are open for questions if anyone has any comments, questions. And we, just a moment, if we can talk through here so we can all hear you, that would be great. Thank you.
The one slide you showed, the PRP, was a pulse or was a conventional PRP? The slide.
Oh, I can talk. Okay, great. That patient was not mine prior to seeing it. So that's the first time I saw the patient. I saw him as a consultation. They had retinal edema. I went ahead and treated it, and vision remained the same. The edema went away, and sure enough, you look at it later, and foliar vascular zone was shot, and the ganglion cell layer was shot, and so all the previous treatment that was done on that patient probably did harm.
Thank you.
Thank you. Any other comments, questions? Yes.
I have a quick question. Among your DME patients, how many do receive a combined therapy? So in anti-VEGF injection plus the laser?
I have a tendency, I talk it over with the patient and discuss, the risk of using anti-VEGFs, and they understand it, and most of them accept it and will have anti-VEGF therapy. If they had any previous history of stroke, or in the last 6 months had stents put in, something that looks that's going to be vascular in orientation, I'm very hard pressed using anti-VEGFs. I will try a MicroPulse first and see if I get a nice response. If we don't get the response we're looking for, then we can discuss anti-VEGFs again, but by that time you're kind of pushing the window a little bit further down the road, so hopefully, their risk factors of having another stroke or having a cardiovascular event will go down.
Thank you. Just a moment, we have a question over here.
Thank you. I was wondering, have you tried reducing first edema with anti-VEGF and then kind of trying to prolong it with MicroPulse afterwards?
Absolutely, yeah, there's no question about it. I mean, if someone comes in with real thickened edema, diffuse edema, and you want to go ahead and pre-treat them with anti-VEGFs, absolutely. If you look at the DCR Net Protocol 1, that's what they did. For the first 6 months, go ahead and treat, and then add laser or conventional, laser at that point. I think with MicroPulse, though, I think you can start thinking about using it much earlier. Whether you want to start off with it and then see what kind of a reaction you're going to get, or start off with maybe 1 or 2 anti-VEGFs and then go ahead and add MicroPulse. Lecture earlier today talked about using anti-VEGFs, MicroPulse, and still continuing the anti-VEGFs for a period of time too. So there's all these different ways of treating. The problem is obviously we don't have any, big double mass studies, centers and stuff like that. A lot of this is anecdotal. A lot of it's from us bringing our cases forward and having people just talk about it. And I think what you have to do is kind of look at the patient, try to figure out what may work best for them.
Thank you. Did you have a question? Any other comments? Okay.
Great, thank you.
Great. Well, thank you very much.